But then once the guys start talking, it's like watching.
Thank you, everyone. Good afternoon. We're gonna get started. Thank you to everyone who's joined in person and our larger group of people online. It's really a pleasure to be able to introduce our speaker today, Dr. Kellan Baker. I'm glad I was asked to introduce him, and I don't even know if the person who asked knew that we're actually friends and colleagues. So it's a great pleasure, and I promise to stick to the professionally prepared bio and not add in any other commentary.
None of those stories. At least not until
Later, during the reception after. So Dr. Baker is the executive director of the Whitman-Walker Institute, which is the research, policy, and education arm of Whitman-Walker, a community health system in DC affiliated with a federally qualified health center. Dr. Baker is a frequent advisor on health equity, research, and policy, with a particular focus on LGBTQ+ populations, and he holds appointments as affiliate faculty in the Departments of Health Policy and Management at the George Washington University and the Johns Hopkins School of Public Health. He received his PhD in health policy and management from Johns Hopkins, where he was a health policy research scholar and centennial scholar, an MPH and MA from George Washington University, and a BA with high honors from Swarthmore College, right near us. So pleasure to introduce Dr. Baker, who's a great speaker, so you're in for a treat. And the way.
Thank you so much, Aiden, and thank you everyone for your warm welcome. As you heard, I did go to Swarthmore, and then all my friends moved into the city and I moved abroad. So I always appreciate a chance to get back to Philadelphia, and I'm very thrilled and honored to have the opportunity to talk with you about, unfortunately, the states versus science, the politics of transgender healthcare. So I'm going to talk a little bit first about the legislative and litigation landscape, just so that we have a shared understanding of what on earth is going on out there. Because if you haven't been trying to keep up, which trust me, I don't blame you, there's a lot that's going on. There's a lot that's happening, and there have been a lot of rapid shifts, changes over just the last couple of months alone, let alone the last couple of years. And all of this has a great deal of relevance, wearing my C3 hat, for 2024, where we will see this landscape likely change even further. So just looking at how things have changed over this is even the last less than 15 years, looking at the number of anti-LGBTQ bills that were introduced and passed. And you can see we're kind of puttering along at a low level here in 2015. Why was there a spike in 2015? Any thoughts? Marriage equality. Obergefell, the Supreme Court decision that extended marriage equality nationwide and clearly pissed some people off. And that is a theme that is one of the drivers behind why we're seeing these, why we're seeing these numbers continue to tick up and up and up in 2020, 21, 22, and into 2023. So that red line there is the number of bills that were introduced, and the blue bars beneath are the number of bills that have passed. So this is really not a wave so much as a tsunami of anti-LGBTQ legislation. There we go. And if you break that down into, there's a bunch of different types of legislation that are included in this red line and in these blue lines here. These are, for example, bans, don't say gay or don't say trans, right? In settings such as schools and other educational settings. These are book bans, drag bans, bans on gender-affirming care, which we'll talk about in more detail, but really sort of a whole huge panoply of attacks on the ability of LGBTQ+ people to live and participate in social and political life in this country. And when you focus in specifically on healthcare for trans people, you can see, again, this is one of those classic, almost hockey stick exponential graphs here that show just the change in the last year alone. This has gotten us to this landscape. So for those who like to follow these kinds of things, the LGBT Movement Advancement Project is my absolute go-to for information about what is going on at the state level. This map shows bans on best practice medical care for transgender people. Thank you, Jen. I was afraid to touch it again last time. You know, I majored in astrophysics 10 million years ago, but let's be real. Technology. So this gets us this map that shows where these bans on best practice medical care for transgender people have gone into effect. So this is in 22 states. Now, although almost 40 states have seen these types of bans introduced. Most of these bans focus on care for minors, but increasingly we are seeing them moving towards adults as well, which I'll talk about momentarily. Some of the things that these laws do, they have their own certain peculiarities in different states, but there are a great deal of similarities that if you track backwards, you look backwards, you will find that they originate from a common source, which is, again, an organized political effort to marginalize specific groups of people, to keep them out of social life, to keep them out of political life, to make it impossible, in this case, for transgender people to live openly and authentically as who they are. So some of the commonalities that we see here include banning care and social support outright, prohibiting insurance coverage, quote unquote tort reforming, and I'm using air quotes here, malpractice lawsuits to extend the statute of limitations 15, 20 plus years, and to allow, for example, the parents of a transgender person to bring a lawsuit against the provider who has provided care for that parent's child, even if that child does not want them to, even if that child as an adult does not want them to. Banning referrals and including aiding or abetting language, outright criminalizing providers and or parents, either with civil liability or criminal liability, and stripping funds from state-funded entities. This was a new one in 2023, where we saw, for example, the University of Oklahoma had funding withheld by its state legislature until it agreed to close its pediatric gender-affirming care clinic. And as I mentioned, these all right now tend to focus on minors, but we are seeing an increasing trend in taking all of these nasty things and applying them not just to minors, but to adults as well. So the orange line at the bottom is the number of these bills that explicitly focus only on minors, up to, for example, age 18, although 20, 21, 25, 26. And the number of the red line above shows the laws that are starting to incorporate definitions that include not just minors, but people of other age groups as well. One of the major places where you can see that happening, that movement towards banning care for adults as well, is in state Medicaid programs. Florida, for instance, has recently enacted a ban on Medicaid coverage for gender-affirming care for transgender people of all ages. That law has been blocked in court. I was actually one of the expert witnesses that testified against it, but where that will go, we'll talk about the litigation landscape shortly. But emphasizing this focus on Medicaid, and in a state like Florida, these bans are not just a problem for trans people, and they're not just a problem for trans people from a sort of broad-based, it hurts everyone equally perspective. These bans are a racial justice issue. They're an economic justice issue. The people who are in these states where these bans are passing, we've often just been told, well, just tell them to get out, leave the state. That's not an option for so many people, particularly in this area of the Southeast, where you are starting to see an increasing number of bans. And as I mentioned, this is part of a larger coordinated effort that is targeting not just trans people, but bodily autonomy broadly, targeting the ability of individuals to make personal private decisions about their own bodies. These maps, if you think back to where the bans were that have been enacted on gender-affirming care for transgender people, it is basically identical to this map that shows where abortion bans are proliferated since the 2022 Supreme Court decision in Dobbs. And if I were to put up a map that shows where gerrymandering and voter suppression is most prevalent, it would be exactly these same states. It is not just about trans people, it is about bodily autonomy, it is about the ability to fully participate as a member of society. And it is targeting trans people, it's targeting LGBTQ people broadly, it's targeting women, It's targeting Black and brown communities, it's targeting immigrants. This is part of a coordinated push to give a small minority of people a great deal of power over how others are able to live their lives. The landscape isn't all bad. There are some good things that we are seeing happen. For instance, in the states, conversion therapy bans, about 20+ states now ban conversion therapy. Expansion of insurance coverage in some states. In Maryland, for example, we recently passed legislation that expanded the availability of coverage for medically necessary care for trans people under Medicaid. New non-discrimination protections, shield laws, which I'll talk about momentarily, easing licensure processes, recognizing that some people are moving. There is an internal displacement of what have been termed medical refugees within the United States as people who have the means. And again, this is a racial justice issue, an economic justice issue, as people who have the means are fleeing the states that are enacting bans. Some other states are seeking to make it easier for example, family members who need a license to practice in any given industry, making it easier for them to move and get a job, and things like expansion of telehealth. And speaking of shield laws, so this is that map. You can see it's sort of almost inversely. These little green indicators here are where shield laws have been enacted since the beginning of this legislative attack on transgender people. So right now we're moving increasingly towards an America that looks very much like that Roe v. Wade post-Dobbs abortion ban map, where half of the states are seeking to protect transgender people and the other half are explicitly targeting them for restrictions on best practice medical care. So shield laws is one way that some of these states have been trying to protect transgender people. If we were in a law, for those who are interested in the law and thinking about how states relate to each other, this is a pretty dangerous situation to be in. A lot of these laws, both on the protective side and on the aggressive side, I guess, have interstate implications. And how states interact with each other and how they recognize or do not recognize each other's laws is a major area of constitutional concern. And we are now setting ourselves up for quite, to put it nicely, interesting scenario when especially the courts begin to consider what this means. So that kind of divided map, divided states, gets you divided courts. A lot of these states have been sued over their bans by groups such as Slam the Legal, the ACLU, the National Center for Lesbian Rights. In some states, and this was an early indication that looked very positive, in some states, bans are being overturned, enjoined, or paused. In Arkansas, for example, which was the first to pass a ban on best practice medical care for transgender young people, there has been a permanent injunction that has barred the law from going into effect. Florida, there are actually two separate injunctions that currently stand blocking the state bans from going into effect, in Indiana. Then we started to see a trend in the opposite direction, where we started to see some of these federal district courts allowing bans to go into effect. Alabama, Georgia, Kentucky, Missouri, Nebraska, Oklahoma, Tennessee, and Texas to date. And there are a handful of states that are pending a first decision. So when you have divided states and divided courts, many of these are in different circuits, right? So there are the federal district courts, which is where these are being heard. And then the appeals move up to the federal appellate courts, the federal circuits. And when you get a circuit split where you have two different circuits, two or more different circuits that have come to different conclusions, you end up in the Supreme Court. So Tennessee and Kentucky are in the Sixth Circuit, which had a very nasty decision authored by a judge who sought to use the rationale that dismantled Roe v. Wade to argue for why transgender people should not have access to best practice medical care consented to by their parents if they're minors and prescribed by their doctors. So recognizing that that is a decision that cannot be allowed to stand, the ACLU and the National Center for Lesbian Rights have asked the Supreme Court to hear this case. This happened maybe 2 weeks ago. And the Department of Justice has recently filed a petition for cert, also asking the Supreme Court to hear this case. So this is a major moment in transgender rights and transgender health. There are a number of constitutional claims, due process, equal protection, First Amendment, that are at stake in this case. We do not know if the Supreme Court will take it up, but regardless, we have moved very rapidly. If you remember the beginning of those graphs where we were kind of puttering along at like a handful of laws every once in a while, to all of a sudden, this incredible explosion of attacks on trans people. This is a reflection of how fast this is moving and how serious these questions are. Meanwhile, Congress, nobody knows what Congress is doing, honestly. But so that was looking at what the states are up to. And as I mentioned, the state landscape is looking hideous right now. States across the country, it's not just restricted to a handful, but states across the country are literally banning best practice medical care. I transitioned in Russia, and like honestly, it's only now minorly more illegal in Russia to transition than it is in Florida. It's basically the same situation. So that's what's happening in states, that's what's happening in the courts, and then on the federal level, we have another branch of government that is paying a lot of attention to what is going on around access to care for transgender people. So this person in the middle is Marjorie Taylor Greene. Is anyone here from Georgia? Okay, good, because I was going to say you need to get your girl. She's in a lot of trouble. And you can tell that, right? This is not truth in advertising right here. She has sponsored. Who is familiar? Hands up, please, with the Hyde Amendment. So what does the Hyde Amendment do? Blocks federal funding for abortion. Exactly. So it's an appropriations rider. It's been introduced, included in every appropriations process since the 1980s. It bars the use of federal funding for abortion, which again is a racial justice issue, an economic justice issue, because what is one of the biggest programs, bless you, that's targeted by that? Medicaid. So Marjorie Taylor Greene has sponsored the Hyde Amendment Plus for gender affirming care. Not only would her bill prohibit the use of federal funds, it would also criminalize doctors who provide care. It would prohibit the performance of any gender affirming procedure or other medical care at any facility that receives federal funding, which between Medicare and Medicaid is literally everyone. And for providers, this is like the cherry on top of her horrible sundae, for providers who are here on immigrant visas, they would be subject to deportation. So that's Marjorie, very busy, she's very, very busy. Does anyone know who is this? Speaker of that, right, who is Mike Johnson? A month or two ago, we were all asking that question. No one had heard of Mike Johnson, but those of us who follow gender affirming care actually know Mike quite well. This was from the summer, so long before his name was even mooted anywhere near the leadership of the House. He is presiding over a kangaroo court hearing on gender affirming care. It's called, quote unquote, the dangers and due process violations of, scare quotes, gender affirming care for minors. So it was nothing more than a parade of ignorance. And he is one of the few members of the House who was willing to spend not just a couple of minutes, not just a comment on the floor, but literally hours of a hearing where he spread lies, there's no other word for it, about who transgender people are, what care for transgender people looks like, and what the role of the government can or should be in making access to that care, making that care accessible. This is a still over here from that hearing. This is a representative from Texas. He is here to let you in on a major secret. The transgender agenda. You see his picture there? Mm-hmm. His idea is that if we make sure that young people can access evidence-based medically necessary care prescribed by their doctors and supported by their parents, that we will then somehow also rewrite the food pyramid so that we can have ice cream for every meal. So I'm here to, I mean, actually, I agree with that. The trans agenda is ice cream at every meal. He was really proud of this. He like had it out and was like yelling about it, and we were all like, "Are you sure? Like, is ice cream fine? Ice cream, that's fine to me." But so these are the kinds of things that are happening on the Hill, taking governing very seriously, but with some serious implications for transgender people. So the federal legislative initiatives, there are some good ones in green. Transgender Bill of Rights, there's a resolution condemning anti-trans attacks, Do No Harm, the Gender Affirming Care Act, which seeks to expand research on gender affirming care through NIH. But then we also have these very, very serious pieces of legislation that are being introduced. This is Marjorie Taylor Greene's Hyde Amendment for gender affirming care. There are authorization riders, for example, seeking to strip children's hospitals of funding for graduate medical education unless they agree to not see transgender people ever, and appropriations riders. So this is again taking a page out of the Hyde playbook, and this is just an example looking at, these are the 12 appropriations bills that fund the government every year. I apologize that it's so small, but every year we have to pass these bills. They are must-pass bills. They are literally what keeps the government funded and open. We are on a continuing resolution right now because the government, Congress cannot get its act together to pass really any of these bills. And one of the reasons why they have not succeeded in passing any of them is that the leadership in the House, which is controlled by the Republican Party, has added riders for prohibiting gender affirming care, so-called license to discriminate, which is essentially a big expansion of conscious or religious exemptions, drag bans, bans on flying pride flags, prohibitions on non-discrimination protections that include LGBT people, and prohibitions on DEI initiatives. All very clearly important for national security, that we hold up literally funding the entire government so that we can try to pack the bills with these kinds of provisions. And 7 out of the 12 bills have at least one, and some of them have more than one bans on the provision of gender affirming care. The other part of the federal government, the executive branch, the Biden-Harris administration, has been doing its best to be busy to try to push the momentum in the other direction. As you heard, the US Department of Justice has filed a request for a petition for cert in the Supreme Court case. There are also a number of lawsuits in various states where the Department of Justice has intervened on behalf of the plaintiffs who are seeking gender affirming care. There's also a pending final rule on Affordable Care Act Section 1557. That is the statutory non-discrimination provision of the Affordable Care Act, which prohibits discrimination on the basis of race, color, national origin, age, disability, and sex. So in 2020, the US Supreme Court ruled that sex non-discrimination protections in federal civil rights law in the employment context include sexual orientation and gender identity, because you can't discriminate against a transgender person without taking sex into account. That's the whole point. But this is still at question in some of the lower courts. So this is again an area where we're seeing rulemaking from the federal executive branch, and things are tied up in the courts, and we're not quite sure when and how Section 1557, the final rule, will land. HHS is also doing other things. You can see in the middle here, that's Admiral Rachel Levine, the highest ranking openly transgender administration official confirmed by the Senate. She has been doing things like traveling, or she's been in Philadelphia, visiting some of the clinics, visiting some of the community centers, trying to let people know that the federal government, at least one part of it, is on their side. And then things like extension of the COVID-19 public health emergency telehealth authority. There's also, for the researchers among us, NIH recently held a workshop on expanding the evidence base for gender affirming care for trans and gender diverse populations. So that is available online, and it lays out a pretty comprehensive research agenda, looking at everything from the sort of biological processes related to how gender affirming care works, all the way to looking at the effects of these types of laws and policies on the well-being of transgender people. So that's the landscape. I sometimes call it a hellscape, but I'm trying to be positive. There is so much that has happened that has been, I would say, shockingly negative over the last couple of years. I started doing work in federal policy in 2008, before the Obama administration, before the Affordable Care Act, and for about 10, 12 years there, it was a lot of progress. It was progress on marriage equality. It was progress on civil rights protections. For example, Section 1557 of the Affordable Care Act. We saw a lot of states, Pennsylvania included, getting rid of exclusions targeting gender affirming care in different types of insurance. Even under the Trump administration, not a lot changed until these last couple of years. And I would love to talk with you all. I want to run through a little bit more about what we can do as public health professionals, but would love to talk with you all too about where is this coming from? Because dealing with it necessarily requires us to understand where it's coming from. There are some clear links. Again, as I mentioned, abortion, the desire on the one hand to control other people's bodies. That is something we do exceptionally often here in the United States. If you think about our punitive immigration policies, if you think about the American carceral state and how many people we warehouse in federal and state prisons, that is all part and parcel. And of course, it's no surprise then, if you have a felony conviction, think about what that means for your right to vote. All of a piece around this question of who gets to participate in public life. But then there are also some other elements that look like they might be at play. For example, if you've been paying attention to any of the discussions from some of the leading presidential candidates, as soon as abortion is mentioned, what do? Pivot. Pivot. They don't want to talk about it. Why not?
People losing.
Because they're losing. Yeah, they're losing in the court of public opinion, and they're losing at the ballot box around abortion. They have finally, they did that thing, you know, you get the thing that you want and you discover that maybe it wasn't what you wanted after all. So the overturn of Roe v. Wade has opened up a lot of questions about, well, what does that mean about abortion access? And the party that pushed hard for overturning Roe v. Wade is finding out that their position is not very popular. And so in order to distract from the conversation about abortion, the target has now become gender affirming care, which in many ways serves the same function, right? Because again, about command and control of other people's bodies. It's also a very helpful distraction, if you will. I know many folks in here think a lot about, work a lot on issues like climate change. It's an excellent way to distract the electorate from the fact that you don't have any answers to the fact that Florida is sinking by prosecuting this war.
Is it not fast enough? It's not so bad.
You know that GIF? Does anyone see where Bugs Bunny is like sawing off
Yeah.
Florida? There's lots of lovely people in Florida, and also, come on, everybody. It's really rough. So it is a coordinated effort to distract from the problems that are really happening, that are really pressing and facing all of us in our communities every single day, by focusing on this manufactured boogeyman of trans people getting access to medically necessary care provided by their doctors. A true boogeyman, if I ever heard one. Actually, there's some polls that have shown that the #1 topic that Republican voters are thinking about going into 2024, the #1 problem facing this country is trans people. So I've got to tell my mother, like, I'm the Republican Party's biggest boogeyman. Like, you really can become anything. Liberal arts education is fine. Grow up to be whoever you want. So there is a great deal of distraction that is going on, and it has a very specific political and social purpose. So that leads us a little bit into what can public health professionals do. One of the reasons that this issue has gained so much momentum is disinformation. And I use disinformation specifically, not misinformation, Misinformation is something that's wrong. You can be excused for getting something wrong. There's lots of stuff that we don't know. You can be excused for not knowing everything. Disinformation, by contrast, is literally propaganda. It is weaponized misinformation that is spread for a political purpose. So disinformation is really running unchecked, and it is being bolstered by, among others, mainstream media outlets. This is from the New York Times. In their very best pearl-clutching moment, they lost puberty is their cost. Concerns are growing. Next up on the nightly news. Concerns are growing. Do you know where your children are? Whose concerns are growing? If you actually look at the background of what's going on here, you can see, for example, this list of the organizations that are out front and leading this push for banning best practice medical care for transgender people. You'll notice something in common about many of them. Look at the year of their founding. Right around the time when we started to see this huge uptick, this huge sudden attack on transgender people. This is not a real controversy. This is not a real problem. It is manufactured by groups who, if you look into the background of these groups, a lot of what they do is conversion therapy. So as we've been seeing the advance of bans on conversion therapy, we are seeing a retrenchment of people who think that the appropriate approach to transgender people and trans young people in particular is coercive, punitive therapy that seeks to change who they are. By contrast, whose concerns aren't growing. Literally every single major US medical association and the World Health Organization, which I don't think is on here. Every single one of these major US medical associations has issued a statement, guidelines, you name it, supporting access to best practice medical care for transgender people. So the both sides now approach, the 50-50, is not actually true. It's not actually a real reflection of these people, a tiny, tiny, tiny minority of groups that have been astroturfed, that have popped up in the last couple of years, versus literally every US medical association. And this disinformation playbook, I include this slide because I think it does a somewhat confusing but ultimately useful job. This is from my friend Meredith McNamara at Yale, who studies the role of disinformation in pushing attacks on best practice medical care for transgender people, abortion and other reproductive health services, PrEP, because that's another one. There have been some federal court decisions that have implicated access to PrEP for people who need it, regardless of sexual orientation. But what you can see here is how this disinformation playbook is working. And in green, that is what's said about abortion. And in pink, that is what's said about gender affirming care. So telling lies, for instance, about the condition for which care is being sought. Talking about how trans people aren't really who they say they are, that it's all just pure influence, they just need therapy, that pretty much everybody who thinks they're trans to begin with ends up not being trans, et cetera, et cetera. None of those things are true. Telling lies about the safety of treatments, that puberty delay medications, which have been well studied and used in cisgender and transgender young people for decades, have purported negative consequences, that transition causes suicide, lies about standard practice, distortions of the evidence supporting the benefits of care, and all of these are leading. I'm told that this is a sports analogy. I wouldn't know. There is a little glitch for me, but all of these plays lead to this ultimate goal of a rebuke of medical authority, a rebuke of scientific authority, which as public health professionals, we are very familiar with. Because this is exactly what happened in COVID. Lies about the condition, lies about safety, lies about standard practice, distortions of evidence, all leading to, honestly, public health officials being driven out of their jobs. And hundreds of thousands, millions of people dying as a result of a coordinated attack on medical and scientific authority. We are trying to do some things about this. At Whitman-Walker Institute, for instance, we convene a coalition called Protecting Affirming Care for Trans Youth, PACT. We launched that in 2022 in order to provide a forum for professionals, health professionals, to come together and work to dispel disinformation around gender-affirming care for transgender people. We're actually now more than 600 providers from every state. And we do things like a weekly newsletter, regular meetings, and summits on topics such as working with the media, legislatures, safety, care for Indigenous, Two-Spirit, and AIPN populations, rural health, and working within religious health systems. And of course, continuing to explore that connection between these attacks on trans people and attacks on abortion and reproductive health and justice. So these are some of the things that we help folks do. I present this to you, encourage you to come learn more about the PACT Coalition, or even just to work with us outside of that coalition. We support experts in providing testimony, meeting with decision makers, writing op-eds or letters to the editor, educating the public, speaking with the media, and getting our networks aware and active around the threat that these laws pose, not just to trans people, but again, to all of us who care about making our own decisions about our own bodies and about the importance of science and facts. So in terms of combating disinformation, we think a lot about this. In public health, we're very familiar with communication, right? It really matters how you communicate with members of the community that you're trying to reach. It really matters how information is presented, because science, medicine, facts don't stand on their own. As much as we would love for them to, they don't. They need our help to get out in front of the people who need to hear them. So a lot of the work that we do is focused essentially on media and communications, telling the story of what's happening, telling the story of disinformation, and providing the truth about what is really going on for trans people, for their parents, for the communities that are being targeted by this type of legislation. So we work to illustrate concrete harms. This is not just a war of words. It has actual physical consequences for people. People are being investigated by the state. Providers are in danger of losing their license. Young people are losing access to care. You want to talk about what's experimental, stripping a young person of access to the medically necessary medication that they've been stable on, ripping that away from them and saying, well, gee, I hope that works out. Well, that is a cruel science experiment. And that's exactly what's going on in these states that are banning best practice care. Emphasizing the role of parents, these decisions are not being made in a vacuum. We know that gender-affirming medical care has tangible, physical, mental, and psychosocial benefits. I would know, I worked on the systematic reviews that undergird the WPATH, the World Professional Association for Transgender Health, Standards of Care, version 8. Those standards have been maintained for more than 40 years. They're continuously updated, and we did, I mean, my eyes are probably still bleeding from the number of spreadsheets that we were looking at to come to the latest edition of the WPATH standards that really draw on even more than 40 years, actually, of medical literature and practice around how to provide best practice medical care for transgender people at different ages. We talk a lot about the threats to medical providers and health professionals. Again, this is very comparable to what we have been doing to try to elevate the experience of public health professionals around COVID, reinforcing medical necessity and describing medical care, and not following anti-trans pundits down rabbit holes. This is one of the hardest things, I think, for many of us as researchers and science people. We want to talk about the science. We go and go and go and go, and it is not about a rational discussion. It is about a gotcha. So trying to work with professionals in various fields, but particularly in public health, medicine, trying to help all of us understand how can we get the facts and share the facts in a way that makes a difference for helping people understand that even if this care is new to you, even if trans people are new to you, the science isn't new, the clinical practice isn't new, and a ban is anti-public health. So these are some of the ways that we describe, for example, the concrete harms that these bans have on both young people and their parents. This is really extreme. As you saw again from that graph at the beginning, puttering along before suddenly shooting up, this is really extreme. It's coming from a very extremist political position. Bans medically necessary care for trans young people, and it allows the state to overrule parents. This is a tough one for us as public health professionals, because we know that parents are not always the most rational or logical or health-focused people in their children's lives. But on this particular issue, when we are talking about a rare condition, gender dysphoria or the experience of being transgender that needs medical intervention, parents are an integral part of the process, working with their kids, working with providers to get them the care they need. Allowing the state to reach in to that relationship is setting a really dangerous example for where we're going in terms of access to other kinds of medical care as well. Politicians putting the well-being of transgender youth at risk, really talking about this from a framework that unfortunately resonates with many of us. This is about bullying. It's about using a position of power to push other people around. And that is something that we as public health professionals work assiduously against. And it is no different when it comes to the question of politicians bullying kids and their families. Medical care for trans youth has clear benefits. I'm happy to go down any rabbit holes, any details that folks want about what this literature actually looks like. What we know is when trans young people receive the care they need, they're able to thrive. Denying that care causes serious harms. Again, this isn't about pushing a radical agenda with young people. It is about allowing doctors to do their jobs. And it is setting kids up. This is something we know in public health, ACEs, right? Adverse childhood experiences. What happens to you as a child sticks with you. Being treated as a political football by a powerful entity like a state legislature or a governor hurts you. That is part of the story that is not getting out there, that is not being heard as much as it needs to. So we reinforce medical necessity in describing medical care. You've heard me say it. I'm trying to work on this gender affirming care. We're doing a lot of messaging work that's helping us understand what messages are reaching people and what people are understanding versus what's still a concern or what's still an area where they feel like they don't know enough. Gender affirming care is turning out to be unfamiliar to many people. So we consider it best practice to use descriptions like medically necessary care, essential medical care, prescribed medical care. We're also learning that the term transition, which is an older term for gender affirming care or an older term for gender affirmation, often brings up ideas of surgery. And again, so what we're really talking about here is not surgery on kids. We are talking about supporting kids and listening to them when they tell us who they are and allowing them, their parents, and their providers to make their own right decisions. And again, not follow. This is up here for me as much as for any of us. Do not follow down any rabbit holes. So these are just a last summary of talking with colleagues, talking with the media, talking with decision makers. Anytime, and again, I bring this up because it's really important that all of us are here using our authority and expertise as public health professionals, as experts in science, to tell people that there is truth, there is fact, and then there is not fact. There is disinformation. And we need to be doing the work to make sure that the science reaches the people who are in a position to be making decisions. Reminding people again, just because trans issues are new for some people, does not mean that the science is new, does not mean that the clinical practice is new. This care is individualized, it's age appropriate in an ideal world. And what these bans do is actually institute the exact opposite of that, a blunt instrument that does no one any good. So you all are health experts, you speak for the science, and I look forward to a conversation about the landscape out there, what you're seeing, and what we all can be doing to continue to create communities all across the country where everyone is free to be who they are. Thank you. This is my contact info. You should feel free to reach out.
Great, lots of claps from all.
Thank you, Kellan, for that. So I'm Jen Taylor. I'm the Interim Associate Dean of Practice, and we're going to open up the space for some questions, comments, conversation, and then at 3 o'clock, we're going to go into the lobby for reception, so there'll be more time for deeper conversation. So Mariel is looking at the chat for me here, so we'll wait for those questions from our folks on Zoom to give your comments or questions. If you want to speak, let us know, and we can do that. So from the room right now, are there questions, comments, reflections?
Please, Jen. Thank you so much for this talk. It was really, really informative. And you used a term throughout the presentation, and now forgive me if I say it not exactly the way you did, but something about best practice care.
Best practice medical care.
Best practice medical care. And I do healthcare research, not in this space. So I know for the types of diseases that I study, what are the organizations that say, oh, you should go read the NCCN guidelines? And like, I know where to point them to. So what would, if you were speaking to a media, or if you were talking to someone and you wanted to point them to, oh, you should actually look up the best practice medical care for that age group or for that. What would you suggest? There's a lot of names there.
Spend them this whole list.
What's the best one on that list?
So there are two, there are essentially three organizations, more or less, that maintain either standards of care or statements about best medical practice. The standards of care, the #1 expert standards in this field, are the World Professional Association for Transgender Health. This is the group that's been around for 60 years. It has maintained the standards of care since 1979. These are the ones that are now in their 8th edition. And this was compiled by over 100 experts in transgender health from around the world. And every recommendation in this standard of care was subjected to a Delphi process. It was only adopted if it had 75% or greater consensus behind it. So this is a very substantial, very weighty guideline that is the #1 sort of place to go for understanding transgender health and for practice, medical practice with trans people. The other major clinical guideline is the Endocrine Society. So that was developed initially in 2009 and has gone through a couple of iterations that focuses on hormone therapy for transgender people, including puberty delay medications, which I'm happy to talk about in more detail if folks have heard of that, but puberty delay medications and exogenous hormones for the support of transgender people's health throughout the lifespan. And then the last one, they have not published a clinical practice guideline. They've published a statement about this care, which is, where did it go? The American Academy of Pediatrics. So the American Academy of Pediatrics put out their first statement on this in 2018, and they strongly stand behind and support access to best practice medical care. Sorry, but trying to make myself repeat it instead of gender affirming care, because that's really what it is. It is looking at what are the practice guidelines in the field, what do they recommend, and doing that, not doing what the New York Times might suggest is the newest fad in Florida.
Thank you.
More of a comment than a question, but it strikes the parallels around reproductive health and abortion are just obviously glaring. And it just strikes me, though, when we think about what the public health community should do, it took a long time, and I don't know that we're there yet, before abortion and abortion rights was truly embraced by public health as this notion now that I think people say somewhat more freely, abortion is medical care and reproductive health is healthcare. And it's not just women of reproductive age who are out in the streets marching about this, but that it's become more part of the mainstream. And I feel like we're sort of at that place when we talk about transgender health. It's still not in the mainstream of public health. And this idea that best practice, I'm not gonna say it, but best practice medical care is part of public health and part of what we in public health say is, the access and part of our 10 essential services, which is to assure the access to healthcare. Not quite there. So it's just more of a comment that I think we're at the beginning still in many respects within the broader public health community of this being where it should be.
Yeah, and that brings to mind a couple of things. One is the broader reproductive justice movement, right, which has been founded by women of color, pointing out that abortion is not the be all end all of reproductive health. It is about being able to take care of, to safely parent, raise the children that we have, to take care of our families in safe communities. So reproductive justice really expands that framework of just abortion to say not all people who can become pregnant have the same challenges in terms of specifically access to abortion, for instance. What folks need is the safe circumstances in their families, in their personal lives, in their communities, in order to take care of themselves and their families. So I would say that we can learn a lot in terms of thinking about access to any kind of medical care from that framework, again, pioneered by women of color that understand the ways in which it's not just about a specific health service, it's about being able to take care of yourself, your family, and your community. There's two other things that I think we think about a lot in public health that relate to access to medical care for transgender people. One is facts. As a scientist, I find this really offensive. There are facts out here. And this is presented as if there aren't, as if, well, on the one side, there's a fact, and on the other side, there's an opinion, but they're totally the same, right? Like, masks don't work. I'm gonna inject whatever I want to stop COVID. Like, it all comes back to this same rebuke of scientific authority or a rebuke of science. And so regardless of what type of care is under consideration, it's that same question of who is making decisions about who can get that care and on what basis. Is it on an ideological basis or is it on a scientific basis? And the last thing is that, one of the reasons that gender affirming care, best practice medical care is so important for trans people is because trans people have higher rates of mental health conditions like depression and suicidality. That has nothing to do with being trans itself. It has to do with the experience of being trans in a transphobic society. The minority stress model, right, which has been popularized by Elon Meyer, but actually comes from research with lesbian health, more than 40 years ago at this point, looks at the ways in which, and this is applicable to so many communities that live in circumstances of marginalization and oppression, it is those experiences of unjust systems that are making people sick. And that is the type of challenge that we are trying to fight back against when we are pushing for access to the right care, because the right care can't fix everything, but it can really substantially mitigate the consequences of having to live, in the example of trans people, having to live as somebody that you're not in a society that's telling you constantly that it hates you. We need to change that narrative that trans people are hearing, and making sure that they can access best practice medical care is a key component of dealing with those experiences of minority stress and related disparities.
So we have a question from the chat. This is from Allie Easton. Hi, Allie. Allie Easton, I really appreciate you taking the time to talk through this very important topic. Based on your presentation, the research is there. We know that best practice medical care is necessary and needed for optimizing health outcomes. But what should we as health professionals do next? Advocacy, policy translation? As you said, Congress is a huge mess, but what can researchers do to help move the policy process along?
There are a lot of things. Policy happens at multiple levels. It happens at the state level, the local level, the national level, the tribal level. It also happens within our own organizations. So looking for opportunities, providing expert testimony or meeting with legislators, that often, sort of sounds like specifically maybe a Congress thing, but like providing expert testimony really just means sharing the facts. Meeting with legislators, meeting with decision makers, meeting with people who are in positions who have platforms to tell the stories about what's going on here and helping them make sure that they are operating from a place of fact, not a place of fear, not a place of ignorance. It's not a surprise that a lot of people feel like they don't know that much about transgender health. So it is up to all of us to learn more and to help others learn more so that when they're making decisions, they're not making a knee-jerk decision based on the kind of hyperventilating, pearl-clutching, inaccurate descriptions of who trans people are and what medical care for them looks like. So really looking for any and all opportunities, getting up to speed on the science, and sharing that science with everyone in your networks, with the media, with decision makers, with whatever. When you have opportunities like this, I really appreciate the opportunity to talk with you all, with your professional colleagues, with those who are in your field, who have a variety of different expertise, different perspectives, and who can then go out and say, you know what, let's say you're having a conversation about reproductive health, or about something like climate change, or about something like voter suppression, or about any of the other things that are keeping people down and making our communities sick. Drawing the connection, like, you know what is another thing that's happening here? Here is another example. Access to best practice medical care for trans people. This is about command and control of people's bodies, and it is not about taking care of our communities. And as public health professionals, we need to help people do better. Decision makers do better. So that's just a handful of examples, but there are any number of opportunities for us to be vocal and active about when we're seeing disinformation being repeated and spread, when we are seeing people legislating or making decisions from a place of fear rather than a place of knowledge.
That is a great way to end. Thank you so much for that. There's a couple other comments in the chat that we'll try to respond to for those folks who are there. But for our colleagues here in person, we invite you into the lobby for reception, refreshments, some more fellowship and sharing. And let's share our thanks again, and thanks to everyone on Zoom for being with us.